Thank you so much for having this presentation. Ostomy is kind of a hidden thing, and people don't talk about it very much. I think that it's a frightening thing. It's an overpowering. People are just so concerned that it's going to take over their entire life. And, yes, it's a change to your body, but it's not insurmountable. It's not something that's going to be a problem for you forever. So knowledge is the key. It's the most important thing you can do is learn as much as you can about an ostomy. So with that being said, I'm going to work a little bit towards talking a little bit about diseases that might require an ostomy, identify different types of stomas because there are different types, understand some of the coping process and pathways so that you can learn how to deal with your stoma and have a happy life. And identify those support resources, which are probably the most important things we're going to talk about. That's at the end, but we'll make sure that you have information about that. Types of ostomies. An ostomy is a surgically created opening that allows part of the digestive tract or the urinary tract to be brought up to the surface level. The rationale there is that we're trying to shift the bowel or the bladder away from an area that's having some kind of a problem. And it's really the most effective way. You can see the GI tract there. The darker pink is the stomach and the small intestine, and the lighter pink is the large intestine. And the typical ostomies are colostomy, ileostomy, and urostomy. A colostomy is used for treatment of disorders of the large intestine, and it isn't necessarily cancer. It can be cancer of the intestine, but it can also be cancer of female and male reproductive organs, simply because they're very close to the bowel in several different ways. Also includes things like diverticulitis, obstruction for whatever reason, inflammatory bowel disease, and birth defects. This affects younger people and even babies and infants. And trauma. Trauma can also cause the need for a colostomy. This is a picture of the large intestine with all the different parts of it. The large intestine's primary use, or its primary reason to be there, is to store digested food and to provide fluid reabsorption. That's how the stool goes from being liquid, where it comes out of your stomach and your small intestine, and it gradually gets firmer as it goes through the system and finally gets to the anus. So colostomy function actually depends on where the stoma is. Stoma is the actual opening for the colostomy or the ileostomy. Location determines the consistency of the stool. If it's on the right side, it's going to be liquid to mushy. And frequently the stoma is more active just because that storage facility isn't there anymore. On the left side, it can be mushy to firm stool. And the stoma is less active, it's more regular just because there's more storage capacity. When we go to the small intestine, this is where the ileostomy generally is. It's actually right where the connection between the large intestine and the small intestine, down where the appendix is on the right side. This is for treatments of small intestinal diseases like inflammatory bowel disease. Obviously, if there's a large intestinal blockage, you may have to have an ileostomy. They can be post-surgical protection just for a large intestine surgery, which is frequently temporary, but the person still has an ileostomy for a period of time. The small intestine is primarily for digestion of nutrients and absorption of food. The ileostomy is on the lower right-hand side of the abdomen. Fluids tend to be, stools, tend to be liquid to mushy. Unfortunately, there is a risk for skin irritation due to digestive enzymes that are still left in the stool. There's also a small risk for dehydration, and some patients even quite a risk depending on their bowel function. And so they need to increase the fluid intake. And there can be a risk for malabsorption as well if they have really high output. both for food and for medications. A urinary diversion is necessary if the person has a bladder cancer. It can also be a cancer of the large intestine or reproductive organs that have invaded the bladder. So the bladder is removed and the kidneys are kind of reconnected, and I'll show you a picture of how they do that. You can also have a urinary diversion for a neurogenic bladder. That's a bladder that really isn't working well at all anymore. Congenital anomalies, including birth defects, strictures, and certainly trauma. And here's a picture of what's called an ileal conduit, known as a urostomy. The kidneys and little tube that comes from the kidney, called the ureters, are attached to a small piece of the GI tract. And it's segregated out. The GI tract is put back together again, but the stoma is brought out in the lower right quadrant and allows the urine to collect and go directly outside via the ostomy. So when we talk about ostomies, most people are interested in the stoma. That's the part that's on the outside of the abdomen. And they look funky because it's actually the lining of the intestine that you're looking at, which is moist and shiny and wet, and it should be pink or red because it has lots of blood vessels in it. So that's a normal ostomy, a normal stoma. And generally it's budded, it sticks out just a little bit like a nipple. And my little lady on the picture there, she has two stomas. She has one that's on the outside that you can actually see there, and if you look on her right, there's another little pouch tucked right down there in her pants. She looks pretty good too. We're going to talk briefly about pouching principles. Now that you've got the stoma, obviously you have to protect the skin and provide for collection of that your stool or urine. It has to be something that's easy to use and easy to clean. Provide that odor control that everyone wants, and helps to manage skin problems and leakage issues. So we'll talk a little bit about different kinds of pouching as we go along here. One of the most important things in a pouching principle that we're going to talk about is correct sizing of the ostomy opening. If you notice the lower right-hand side, there's a stoma there, and it looks like there's something white around it. And what that is that's a measuring device. It's just a little piece of paper with different sized holes in it. And it's really important to measure that stoma routinely to make sure that you have the right size opening, because that's critical as far as keeping your skin in good condition. The skin barrier is the part that's critical for most patients. In choosing the right appliance, the right pouching system, you have to kind of know what the nature of the stool or the urine, whether you have stool that's liquid or solid, is it urine? Where's the stoma located? If it's close to an incision or a crease or something, you may need to have a different kind of pouch for that particular need. The size of the stoma, that tells you what size of the pouching system you need to order. Are there barriers to obtaining a tight seal? Creases, crevices, body habitus that just isn't quite right for that pouch. Dexterity and vision issues are a real challenge, and some pouches are easier to manage than others. Activities, if maybe you're a golfer, you might want a shorter pouch on the day that you're out to go golfing. And of course, personal preferences come into mind. There are a number of different pouching systems, 1-piece and 2-piece, drainable pouches for semi-liquid or liquid stool that provides you an opportunity to empty the pouch as opposed to letting it fill and then having to change it. Closed-end pouches are really for solid stool. Someone who may have one stool a day, they can actually make that pouch change on a daily basis or twice a day. Urostomy pouches have an entirely different bottom on there. It's more of a spout than it is just a wide opening. And they allow for being hooked up to a drain bag at night for better sleep. So we'll talk briefly about 1-piece pouches. The pouch that you see here is a 1-piece, meaning that the pouch is integrated into the adhesive part that goes on the skin. And the stoma goes in the middle of the little hole that's there. What's nice about one piece is it does offer flexibility. When it's on the abdomen, it lies flat, so it's less obvious. For some people, it can actually provide a better seal for body contours, but it does require removal and replacement to manage stool output. So if you have more than 1 or 2 stools a day, it's really not going to work real well, because we still have to keep your skin intact. And if you remove tape too many times, it can be a problem. And patient preference is important in your selection of what you want to use. 2-piece pouches are usually what you'll see most often post-operatively. Nurses like to be able to see the stoma, so this allows them to be able to do that in one way or another. They can be easier for someone to put over the stoma because you have a piece that's separate, that's adhesive, that sticks on the skin. And then the pouch is attached to that little ring. I like to tell people it's like using Tupperware. The rim of the bowl is the part that's on the skin, and then the lid is the pouch. It offers you the ability to actually remove and replace a pouch without disturbing the skin seal, because the skin seal needs to be on there as long as it possibly can. And it also provides options for different kinds of pouches. This pouch that you're looking at here is a closed-end pouch, but certainly open-end pouches are available too. And again, it comes down to patient preference, what kind of pouch you would like to use. The skin barrier, as I talked about before, is the most important part. That's the part that has protective material in it, and it sticks. And it's generally a very natural product. It's basically methyl cellulose is the base of it. And then the adhesives are different quality depending on the type of stoma you have. They can be a regular wear, or they can be an extended wear. This particular wafer that you're looking at is flat. So the stoma needs to be above the skin level for the stool or urine to fall into the pouch. And they're available in a cut to fit, which is what you're looking at here, and also pre-cut sizes, meaning it comes with a hole that's the proper size for your stoma. There are also convex skin barriers. And if you look at the picture, you can see they actually look much different from the one that you just saw. And these are really appropriate for a flat stoma or a stoma that's pulled in a little bit, it's retracted, and it may even help fill in skin creases and crevices and work with scars. So this is the kind of wafer that people who are having some leakage issues may find more effective because they actually put a little bit of pressure around the stoma and make for a better contact with the skin. These also come in cut to fit. The one that's on the lower part is a cut to fit. You can actually see the little circles on there that you would use to cut. They also come in pre-cut, which is a couple of the other pictures here that you see. Pouches come in transparent, which you'll see post-operatively most of the time. A lot of patients go home with transparent bags, and the rationale for that is you can actually visualize the stoma, you can see it better, you can see what's coming out. Patients that are using one-piece pouches frequently use a transparent pouch simply because they can see the stoma and they can guide their pouch on more effectively that way. The opaque pouch is something that most patients prefer once they're home, and they can also be either closed end or drainable. And they're more discreet simply because you can't see the contents as effectively. But if you're trying to use a one-piece pouch, it is more of a challenge because you can't see through the pouch to place it over the stoma. And the pouch in the middle is my one example of a urinary pouch. If you look at the bottom of it, it has a different kind of a bottom, and that's like a little twist valve on the bottom. And you can also connect that to bedside drainage. The one on the right is a drainable pouch. It's also in a different shape from the others that we've seen so far. So they're all different shapes as well. So in talking about ostomy care, it's important for people to understand that a drainable pouch, the part that goes on your skin really only gets changed every 3 to 4 days. And the pouch itself is emptied into the toilet on a regular basis, depending on what you need. Closed-in pouches are generally changed once a day or whenever there's a bowel movement. If it's more than twice a day, you may run the risk of skin stripping, so it's generally not acceptable for patients that have more than 1 or 2 bowel movements a day. Skincare is done just with plain soap and water and rinsing the skin really well, and then gently drying with a towel. No rough stuff because it'll irritate your skin, or just air drying. There are a lot of different products you can use on your skin, and hopefully your ostomy nurse is helping you with that if you need anything. So if you're having skin irritation, they're the best person to go to for that kind of information. You want to empty the pouch when it's 1/3 full. You do that because the weight of the stool in the pouch or the urine in the pouch will actually act as a mechanism for pulling it off your skin. So if it's 1/3 full, that's when you need to empty it. Urinary pouches should be probably put to a bedside drain bag at night, just because if you sleep well, your pouch may fill too much. It needs to be emptied. The kidneys work all the time, so urinary stomas work all the time. Postoperative complications, although they're rare, they can occur. With any surgery, there's always a possibility of infection. Skin irritation is a common problem for ostomy patients, but it isn't something that should be happening all the time. If it is, then you should request the help of an ostomy nurse. But things like chemicals, stool and urine are the primary ones, but it can be other chemicals you might be using on your skin. That's why we ask you to use just simple soap and water to wash your skin. It can be a mechanical problem like tape removal. Tape that's taken off too often takes off the top layer of skin, so you run the risk of having skin irritation with that. There are skin infections. Yeast is the most common, but you can also have bacterial infections, and those are things that would require a physician to assist you with that. And of course, local allergic reactions to products. Those are rare, but they do happen, just like everything else in life. So your ostomy nurse can help you with that. Stoma complications such as stricture, retraction, which is pulling in of the stoma, or prolapse, which is actually where it pushes out, or abdominal wall herniation. They're possibilities, but they don't happen that often. And again, your physician would need to help you with these problems. Obstruction of the intestine from scar tissue or other mechanical problem can happen, but again, it's a rare occurrence. So what do? You want to call your doctor if you're having unusual or increasing pain, redness or drainage from incisions, fever, nausea, vomiting, or excessive output of stool, just more than you would anticipate. If you have a urostomy, if the urine's cloudy or it has a bad odor, you have a backache, just not feeling well, that's the time to call your doctor because you need to see that person. Contact your stoma person if you're having leakage issues or your skin is irritated, because they're more able to look at your pouching systems and the things that you're doing and come up with things that you might be able to do to fix those problems. Each person is unique in their response and their coping mechanisms, how old they are, previous health status, cognitive, intellectual problems, their ability to learn, psychological conditions. Sometimes people already have things that are going on, and obviously the ostomy may exacerbate some of their issues. Their home and their family support is very important to coping. Even things like your profession and even your hobbies can play a part in how you're going to cope and how the changes in the ostomy and what happens with you. Ostomy surgery compromises your body image and how you feel about how you look. And grief, anger, denial, and fear are normal emotional responses, Just because you're angry and upset doesn't mean that something's wrong. It means that you're acting normally to this change in your body. And of course, even the stress from your disease process can affect how you cope. Obviously, there could be loss of self-esteem or even guilt over the loss of independence with self-care. If you're having pouch leakage, gas, odor, these are all things that can really affect your way you look at yourself. You may even question if you can even be sociable again. You can have concerns about going back to a job or even financial stability. These concerns are really important to take into account, and there are ways that you can mitigate some of this, and it's by being able to learn more about what's going on with your system and things that you can do to cope better. Certainly there are concerns about intimacy as well. We'll talk a little bit about that later. On top of all of that are the specific ostomy concerns, things like management of odor and gas. What kind of clothing can you wear? What kind of activity can you do? Dietary concerns. Maxine, bless her soul, she's going to help me with that with her part, so I'm happy with that. Bathing, even sounds, there's just lots of things to be concerned about. So we'll talk about odor management for a minute, because this is patients with colostomies and ileostomies are always concerned about this. The good news is that the ostomy pouches are odor proof. Odor is a sign of a leak. If you're having leakage, you'll have odor. Or if you're emptying your pouch, maybe you're not cleaning the end of your pouch well enough, and so you still have this lingering odor. So it's important to keep that in mind. If you notice something, find out what's going on. There are pouch deodorants, something actually put in the pouch to reduce the odor of the contents. There are actually internal deodorants, oral medications you can take to reduce the odor of the stool. And of course, there are room deodorizers, although you want that just in the bathroom, because when you empty your pouch, just like anyone else who's having a bowel movement, there may be odor, so a room deodorizer can be helpful in that regard. But that's the only place that you need a room deodorizer. Clothing choices. You can wear anything that fits and feels good. Some people have to adjust where their belt line is based on where their stoma location is. If you've had your stoma site pre-marked by the ostomy nurse, hopefully you'll mitigate some of that, but emergency surgeries may cause the stoma to be in a place that doesn't really work well with the belt line. So you have to adjust your clothing choices because of that. Looser fitting clothing may be more camouflaging, but it isn't always necessary. A lot of people use specialty underwear to conceal or even control the pouch. There really aren't any limits to activity once you're fully recovered from your ostomy surgery, but recovery is the issue. You need to make sure you give yourself plenty of time before you try to run the marathon, even though ostomates do run marathons. They play golf, play tennis, they swim. Many of them even perform manual labor. It's not a rationale for having to change what you do in life. Your pouching choices may be reflected in the activities that you choose to do. As far as dietary concerns are most ostomates really don't need to change their diet. It isn't a necessity. If you ate it before you had surgery, you probably can eat it afterwards. You will see a postoperative diet change just for a period of time to make sure that the bowel is rested and a lot of the edema is gone, because you don't want to put something that's really undigestible through a bowel that's already been traumatized. There are some ostomates do need to have alterations to their diet, and that's primary ileostomy patients, because the ileum, when it's brought out to the skin and opened up, that opening is going to scar down a little bit. So the opening is not as flexible as it would be normally. So if you're eating high fiber or stringy foods or things like undigestible popcorn, vegetables that are difficult to digest, fruits and nuts, those are all things that need to be either avoided or great care taken in how you deal with them. You're going to chew your food really, really thoroughly and make sure that you're drinking plenty of water, because you need to avoid dehydration if you have an ileostomy. Sound management. I have this in there because it is a concern of patients with ostomies, particularly colostomies. Unfortunately, some pouches actually have material that's a little bit noisy, kind of crinkly. So there's where your personal choices come in. You know, can you choose a pouch that doesn't have that property? Adding a pouch cover or additional underwear can help reduce that kind of noise production. Stomas can be a little noisy. Gas passing is not controlled because there's no mechanism for controlling stool or gas. And most patients can feel when they're starting to have gas. They can recognize that feeling. So you can put your arm over the stoma as a muffler. And you can always stare at the guy next to you and kind of step away, because maybe they're the ones who did that. Managing excess gas with food choices and medications are also a possibility for you. You can check with your physician or even your nutritionist to talk about the gas formation and what you can do to improve it. Intimacy. This is always a question for ostomy patients, and it's frequently something that isn't talked about very much, because we've been taught throughout our lives we don't talk about bowel movements and we don't talk about sex, which doesn't make any sense because we all do it. So there you are. But make sure you take time to heal. That's the most important part. You know, be open and honest in your communication with a partner. How are you feeling today? What's going on? Focus on your relationship. You know, small things like touching is very, very important. Obviously, if you're going to be intimate, you want to empty the pouch before you become intimate, and you can use a smaller pouch. My little picture there shows a lady with a little pouch cover over her stoma. And there are beautiful pouch covers out there. And that's one way to conceal the pouch. You can use sexy underwear. You can even use something like a bandeau, like a cummerbund kind of thing. In any position works. The important part is that you're comfortable. There are 4 pleasures of sexual intimacy. I learned this myself just in doing a little bit of research for this program. And I really liked what it had to say. The ostomates and their partners still have the ability to share all of the 4 pleasures. Touch, which equals intimacy. That's very important. Something that you can do before you even think about intercourse. Touch. Genital stimulation. That's hard to say. Genital stimulation. Again, very important. It's part of the sexuality. It's part of intimacy, and something that a stoma patient can most certainly have. Orgasm. That's also a pleasure that an ostomy patient can certainly have. And of course, pleasing your partner. That's the most important part of the whole thing. And remember that ostomy surgery is a change in your body only. You're still the same sexual being that you were before. Sexuality is 90% in your brain, not necessarily in your body. There can be potential concerns about sexual activity and dysfunction after surgery. Sexual dysfunction is uncommon, but it can be a real potential. I think the fear of rejection is probably the most common cause. But erectile dysfunction can happen depending on the kind of surgery that someone's has. Nerves that mediate erection, orgasm, and ejaculation all run through the rectal and prostate area, the bladder and the rectum. So both women and men can have problems if the nerves in the area have been impacted in some way by the pelvic surgery. Sometimes these issues of dysfunction are permanent. Sometimes they're just temporary. You need to wait for swelling to go away. And obviously, if you're having a problem, if you're concerned about it, speak to your doctor, because maybe they can help you with some of your concerns. And physically, they may be able to refer you to someone about sexual dysfunction. When it comes to ostomates, it's really, really important to ask questions. If you don't know something, ask the question. No question is stupid, or you just need to know. Ask and learn. It's important to learn your self skills. If you're not doing your own ostomy care, I think that you're missing an opportunity to move ahead in your recovery, because being self-sufficient is very important to that self-image that we talked about before. It's nice to have a support person, because they can learn and they maybe can help you remember something that you didn't remember that you were taught in the hospital, but it isn't absolutely essential. There are a lot of community resource information available. Ask questions about, am I going to get home care? Is somebody could come and kind of help me along with some of this stuff? Where do I get my ostomy supplies? Now, home care is responsible. If you're a Medicare patient, home care is responsible for ordering your ostomy supplies. But once they're gone, you're going to need to order yourself. So you need to know, what do I need to order? How do I order it? Who's paying for it? It's important to know all of these things. Psychosocial supports and financial support. Oftentimes the social worker in the hospital can be very helpful for you, and even the home care has a social worker available. So use those resources and ask those questions that are really important, or something that's bothering you, ask the question. Support is your key. Knowledge and skills are the essential keys to coping and recovering. Your sense of normalcy just won't be the same if you don't have the knowledge that you require. It's also important to interact with those people who can give you that knowledge, the ostomy nurses, the home health nurses, and in my opinion, more importantly, individuals in the community that already have experienced an ostomy. Somebody who can buddy up with you and talk to you about what you're feeling and how they might have coped. And it's invaluable. The ostomy product manufacturers also have people who you can talk to on the phone who can help you troubleshoot some of your pouching issues, and they can send you samples, and they also have educational materials available. So this is the resource part of my speaking. The United Ostomy Association of America is the overreaching national organization that provides educational materials, videos, blogs, conferences. There's a national conference every 2 years of hundreds of people who have ostomies and the ostomy suppliers. So it's a perfect place to get information and education. Online, there are ostomy.org, and it's a wonderful organization. As a member of the Ostomy Association of Los Angeles, we are an affiliated support group, meaning that we function under the umbrella of the United Ostomy Association. And our hotline number, which sits on my desk, is 818-337-8416. So you can call, you can ask questions. I can link you with somebody who has an ostomy, who's been trained and what they need to talk with you about. So it's an important asset. In Ventura County, if you're closer to Ventura itself, Daphne Hodges has a support group, and her phone number is 805-948-5636. She's a wonderful person. I really enjoyed speaking with her. She also has a clinic. Now, ostomy clinics are hard to find. So we're lucky in the fact that we have 2 in the area. One is at Tarzana Hospital with Terry Dodgy, and the other one is Ventura Community Hospital with Daphne Hodges. So both of those are available to you. I've talked to both of them recently, and they will accept patients. So that's a good thing to know. So if you're not on home care anymore, and you're having a problem with leakage or skincare issues, you can call Terry or Daphne and maybe go see them. There are also other support possibilities. One is something called Ostomy 101. It's an app for your phone, and they have listings of all the support groups in the areas, and they also have education. And so it's a really neat thing for your phone. There are 2 Facebook groups that I'm familiar with that are also very good, Ostomy Family and Ostomy Buddies. Both of them, if you become a member of their group, you can post questions, you can post answers. It's amazing what people will offer in the way of information and support for you. So those are wonderful. And again, your manufacturers, they even have support for people who are having problems with obtaining supplies. They're financially not doing well, they've lost their job, whatever it is. The manufacturers can also help with that. So avail yourself to all the resources that are available. I want to thank you for your time and for your just being here. It's important. Thank you.
And talk to you all a little bit more about nutrition and eating with an ostomy. So everybody see my screen there? All right. Okay. So eating with an ostomy. So today we're going to talk a little bit about nutrition. I'm just going to go over some basic nutritional information. We'll talk a little bit about digestion, absorption and elimination, and how the different types of ostomies will impact or can impact absorption and elimination. And then kind of go over some guidelines, mostly for those first 4 to 6 weeks post-op, where you will have to kind of modify your diet. But as Glenda said, eating with an ostomy is just healthy eating, just like all of us need to do. So with that, I will, let's see. First, I'd just like to introduce myself a little bit more and let you know what my role is as a navigator here at Las Robles. As Kaio mentioned, I am a complex GI navigator, and I also navigate lung cancer patients. So what I do for our patients is I'll provide resources and that can be from anything from transportation issues, support groups, health insurance, just whatever the needs happen to be. We have lots of resources, and I help get those to our patients. We also act as a liaison and advocates for our patients, help with communication between the healthcare team, and just address overall concerns, help with questions, and a lot of education like we're doing today. But mostly we really try to provide the emotional support that people need trying to navigate their way through their cancer journey. So that's a little bit about my role. The first thing I really wanted to stress is the importance of reaching out to a registered dietitian. That's going to be your best source for developing an eating plan, especially right after surgery. The registered dietitian can help you develop an eating plan and help you track and just evaluate your own personal needs and preferences. Really important when you're looking for a dietitian to find a registered dietitian. So the initials RD should be behind that title. And just make sure your dietitian knows what kind of ostomy you have. And also, those dietitians are sometimes covered by your insurance, so you want to check your insurance to make sure. So we'll get started with a little bit about just overall eating well. So first thing, as Glenda mentioned, is that everybody is different, and that goes as well with your diet and nutrition. So you're going to learn to eat what's right for you, but overall, you just want to choose healthy foods. And that should be from all the food groups. A good variety of foods is what's going to be most helpful for you. Other healthy choices, of course, try to limit the salts and saturated fats, like we should all do. And most importantly, try to get most of your nutrients from the foods that you eat versus supplements. Supplements may be right for you, but you want to talk to your doctor about them. So a little bit about just nutrition facts. We get our nutrients from two kinds of nutrients, macronutrients and micronutrients. And our macronutrients are the carbohydrates, proteins, and fats. And these are the nutrients our bodies use in larger amounts, and they provide us with energy. So the carbohydrates are broken down fairly easy by the body into glucose, and we use that for our quick energy. Then we have our proteins, which provide the body with energy that's needed to help repair and build cells, and that's all the cells in our body, from our bones to our hair, cells, organs, tissues. That's what our proteins do. That's why they're called building blocks. And then there's fats. Our fats provide us with a longer lasting energy, but they're also important for maintaining healthy skin and hair, body temperature, and hormone regulation. The micronutrients are our vitamins and minerals, and those are needed in smaller amounts, but are equally important. You've got water-soluble vitamins, which means that these are vitamins that are absorbed in water, and vitamin C and all the B vitamins. And the thing with those are that these are not stored in your body, so these need to be replenished in your diet every day. The fat-soluble vitamins, on the other hand, are stored in the fat, and those are dissolved in our diet with the fats that we eat. And then there's the minerals that are calcium, sodium, phosphorus, magnesium, and such. Again, these are chemical elements that are needed in smaller amounts, but very essential to life. Carbohydrates, a little bit more about our nutrition, and proteins and fats. So you're going to see that all these nutrients are found in a variety of foods. And again, stressing that's why you need a good, healthy variety of all the food groups. Carbohydrates are found in milk and yogurt, just like proteins are. So again, you want to eat a good variety of foods to make sure that you're getting all these nutrients. But as you can see, there are some foods that are that contain more of these nutrients than others. Proteins, for example, you're going to find a lot of that in fish and lean meats. Fats are going to be more in oils and nuts. And then there's healthy and unhealthy, and I think we all know the unhealthy ones are more found in things like cheese and butter, high fats, meats, bacon, ones that you want to try to limit in your diet for a healthy, overall healthy diet. And I'll go through just a little bit about the digestive process, just so we can understand a little bit about how absorption and elimination are affected. We know that it starts in the mouth. As soon as we chew food, it starts breaking down with the saliva. It goes into the stomach, and in the stomach, it's going to get even further broken down by all the enzymes and acids in the stomach. It gets churned and kind of stays there until it's gradually and slowly released into the small intestine, which is responsible for absorption of the nutrients. So in that first part of the small intestine and duodenum, that food is still contains a lot of enzymes and acids. So that's where it gets neutralized. That's kind of the job of the duodenum. And then it passes into the next part of the small intestine, the jejunum, where actually most of the absorption of the nutrients takes place in that part of the small intestine. And then passes into the ileum, where we still have absorption. B12, vitamin B12 is absorbed there, and some bile salts. And then it gets passed into the large intestine. And as Glenda also mentioned, this is where you have most of the reabsorption of our water and electrolytes happens. As it goes through up into the ascending colon here, it's more fluid, and then as the fluids are being absorbed, it gets thicker. So the thicker the stool, the more nutrients that are being absorbed until it goes all the way down and passes through the rectum and anus. So the way that these absorption and elimination is affected with an ostomy depends on where the stoma is. In a colostomy, if the stoma is located in the lower part, or in the descending type part of the colon, that's a portion. That means a portion of the colon's been removed or bypassed. So it's already gone through the small intestine where most of the nutrients are being absorbed, and it's also gone through most of the colon. So a lot of absorption has happened, reabsorption of the fluids and electrolytes. If it's located in the transverse part, that means a larger portion of the intestine has been removed or bypassed. And so you're going to have a more decreased absorption of your fluids and electrolytes. And then obviously the ascending is that first part of the colon. And if you have a stoma there, that means most of the colon's been removed or bypassed. So you're going to have a much larger decreased absorption ability of those fluids and essential electrolytes. That's where you may see some higher risk of dehydration. The stool is very liquid still in that part of the intestine. You also still have remaining enzymes in the stool, and that can cause some skin irritation, as Glenda had described also. Now, again, we're going to go over the ileostomy because that is where the entire large intestine has now been bypassed or removed. So there, you're going to have a much bigger decreased ability to absorb those nutrients, some nutrients, fluids, and electrolytes, and a much higher risk of dehydration, which can cause symptoms like sweating, diarrhea, vomiting, and if you did become dehydrated, you may need some IV hydration if it is severe. Also, with the ileostomy, because that's where the B12 absorption happens, that's going to be less absorbed, so you may need some supplements for that. And again, the stool that in that area is going to be liquid to semi-soft or mushy, but for the most part, that's still very liquid. And after surgery, it's usually dark green. You'll also have those enzymes in the stool that can cause that skin irritation if you're having pouch leaks. So you want to remember that. Remember that the thicker the stool, the more nutrients and fluids and electrolytes that are being absorbed. So some guidelines. So again, this is for the first 4 to 6 weeks post-op. After that, as again Glenda mentioned also, your diet should gradually be advanced to a normal diet. But it doesn't really matter what kind of ostomy you have. Those first 4 to 6 weeks post-op, your diet will start with a liquid diet and then transition and advance to a low fiber or low residue diet. And that's, again, for the reasons that Glenda explained. You want to rest that bowel. That's the priority. Promote healing. So a low fiber, low residue diet doesn't produce a lot of stool or gas, and so it allows that GI tract to really rest after surgery. And that helps wound healing, also helps with maintaining your fluid levels, and prevent issues like stoma blockage, which again is highest risk in the ileostomies. But again, to stress the fact that this is meant to be a temporary 4 to 6 weeks, and then you can kind of gradually advance your diet. Yeah, okay. There. So here's a food guide. This is just a guide for a low fiber, low residue diet. And just to let you know that you can find these low residue diets in a lot of these resources that we have through the United Ostomy Organization Association. But I found this, and actually this one I found in their Eating with an Ostomy guide. So it just goes over foods that you want to avoid and foods that are more tolerable on a low residue diet. So you have things like lean meats, poultry and fish. Those are good proteins. Low fat dairy, eggs are okay. Butters like smooth, soft, creamy peanut butter are okay. And the things you want to avoid are the more fatty types of proteins, tough meats, beans, and you're always going to see those nuts and seeds, lentils, peas. Those are harder to digest, so obviously you want to avoid those for that first part post-op period. Breads, low fiber breads, cereals. So you're talking about white breads, rice cereals, rice and pastas. Those are low residue, low fiber. And of course, then you want to avoid the whole wheat grains, whole wheat breads, brands. Those are all going to give bulk, all good foods eventually, but for this first part, for those first 4 to 6 weeks post-op, not a good idea in your diet. Vegetables are going to be steamed or microwaved, no skins, potatoes that are mashed, boiled, or pureed. You want to stay away from the raw vegetables, especially with seeds. Things like sauerkraut, cabbage, cauliflower. Those are all going to be harder to digest and cause more gas. Your fruits, again, also cooked or canned, applesauce, bananas. Avoid the fresh fruits, dried fruits, berries, figs, dates, and no pineapple. And then the milk products, you can do low fat, milk, yogurts, puddings, low fat ice cream. You want to stay away from the full fat milk, cheese, yogurts, and with whole fruit, and cheese sauces like Alfredo sauce. For desserts, custard, sherbets, popsicles are okay. You don't want fruit preserves with seeds, pickles, relish, coconut, or guacamole, which I love, but eventually. So specifically with the ileostomies, there's a couple of things you really want to be aware of. when you're thinking about your diet, and two of those are stoma blockage and dehydration. With the ileostomies, the risk of those stoma blockages is greater for several reasons. It's just that area in the ileum is smaller, so your stoma is going to be smaller, and then you compound that with the normal inflammation that you have post-op. That increases the risk for food to get stuck there. So signs that you would look for blockage that might tell you need to have it checked out. If you're having abdominal cramping and pain, distension, watery stools, well, it's going to be liquid, but it shouldn't have a really bad odor. Also, if the stool is being released in spurts, just spurts at a time, that's another indication you've got some kind of blockage or pressure there. Obviously, the absence of stool output is going to be a big red flag. Pressure at the stoma, and again, little or no output. Those are all symptoms that you want to contact and notify your doctor about immediately to rule out any issue of blockage. The way to avoid them, obviously, is to avoid those kinds of foods that are going to contribute to a blockage, so the high fiber, high residue foods. Again, the raw fruits and vegetables, and just a note to chew your food really well. That will help to avoid any blockage. If you're seeing any visible chunks in your pouch, that probably means that you need to chew a little bit more. So really chew your food well. Some other foods that can contribute to blockage during those first 4 to 6 weeks particularly are going to be things you see on your right: mushrooms, whole nuts, seeds, salad greens. Those things are hard to digest and can cause that blockage. Dried fruit, coconut, and the whole grains and rice. Dehydration, another increased risk with particularly the ileostomies. So you want to avoid caffeine. Uncaffeinated drinks are fine, and you do want to really stay hydrated. That's really going to be the key to avoiding dehydration. So sipping fluids throughout the day. Rule of thumb is to drink a glass of fluid every time your pouch is emptied. Try to drink 8 to 10 8-ounce glasses of fluids every day, and that should come mostly from water, but you can also have water diluted juice or sports drinks. Those sports drinks are good because they provide a little extra electrolytes, but they can be high in sugar, so be sure you dilute those if you're going to be drinking them. Jello, broth, and vegetable juice are also good sources to help you stay hydrated. Avoid those spicy foods, fried foods, again, drinks that are high in sugar, alcohol, and chocolate. Now, I did read, I was looking that up because I said chocolate. That's not fair. But white chocolate, white chocolate doesn't have cocoa powder, so it doesn't have a residue. So white chocolate is okay, but dark chocolate is on the avoid list. Creamy peanut butter is also okay, and marshmallows. So again, overall, tips for success is really give yourself some time, give yourself time for your appetite to come back, give yourself time for your body to heal. Focus on a good, well-balanced diet. Again, variety of foods from all the food groups. Don't force yourself to eat, and try eating small, frequent meals versus 2 or 3 large meals. Eat lots of lean, protein-rich foods, and incorporate meals and snacks in a regular schedule. slowly increase your intake and gradually introduce new foods one at a time so that you can identify any problems. And again, chewing really well, take small bites, that will help with your digestion. And avoid using straws because they can produce gas. I also have lots of resources, and of course, number one on there is the Ostomy Association for Ventura. Glenda also gave you that information. So again, those are going to be some good sources for you. Also, for ostomy supplies, as she mentioned, there is assistance programs, and you'll find that they're in ostomy211.org. They have, and I've used them, they provide supplies for patients who are financially need some help. Hollister, Coloplast, and Convatec are all have assistance programs, and there's the numbers for them. These will be available through Cancer Support Community as well. And of course, Cancer Support Community for nutritional resources. They've got a great, oops, where'd I go? They've got a great virtual kitchen. I was looking through it, lots of recipes and good resources. Again, I lost my page. But anyway, all the resources are available through the Cancer Support Committee community. I just want to say thank you. I lost my last slide with that beautiful scenery. I don't know if you guys are seeing it or not. But I want to thank Cancer Support Community for allowing us to share our information, and Glenda for allowing me to be a part of this workshop. I hope it was helpful. Thank you.